Hello, sir. Good evening.
Yeah, good evening. I will start recording.
Right, sir.
Yeah, today's case number 3 for extrapyramidal syndrome, akinetic rigid syndrome. Today's our moderator, Dr. Swaleha madam, and today case presentation by Dr. Mauli Vora. So, Dr. Swaleha madam, you can introduce yourself and followed by Dr. Mauli. Then we'll start the session.
Hello. Hello.
Yes, yes, madam, you are
Yeah.
audible.
So I'm Dr. Swaleha Nadaf. I'm Assistant Professor, Department of Neurology in Iron Hospital. And I think we can start. She can start presenting.
Yes, ma'am.
Yeah.
Yes.
Hello, everyone. I'm Mauli Vora. I'm third year neurology trainee at PD Hindoja Hospital, Mumbai. I'll be starting now. So this is 77 years old, right-handed male, businessman by occupation, graduate, living at Matunga, Mumbai, presenting with chief complaints of difficulty in walking for past 8 to 9 months, softening of speech for past 5 to 6 months, and change in handwriting for past 3 to 4 months. The informant is patient himself, but the history has been corroborated by son as well. Patient was relatively asymptomatic 8 to 9 months ago. Then he started having difficulty in walking. This was insidious in onset, started with slowness of gait and fear of fall while walking. Although he did not require any support while walking and could manage independently, he doesn't have any history of fall so far. For past 5 to 6 months, however, patient started having trouble initiating walking, especially on waking up in the morning. He would feel the foot to be stuck to the ground, although it was not disabling, and patient could manage to walk with some cues, especially the visual cues. And this would not occur once walking was initiated. According to the patient, this was more noticeable in left lower limb than right lower limb initially, but then gradually it became equal in both the lower limbs. With this, patient started having difficulty in turning, became slow. He becomes slow and imbalance worsens while turning. He would find it difficult to navigate through narrow passages, and patient has started taking short steps and walking cautiously to avoid falls. He has some difficulty in manipulating his way through obstacles or while walking on the unpredictable or uneven surfaces or at crowded places, and would fear falling and become more cautious. Although he denies any swaying while walking or worsening in the dark. Patient also has some history of softening of speech, and he describes it as reduced speech volume for past 3 to 4 months.
I think we can go back to the first page.
Yes.
Yeah. So you are telling that this patient since 8 to 9 months he has difficulty in walking.
Yes, ma'am.
Okay. And there is slowness of gait and fear of fall while walking.
Yes.
But till now he has not fallen.
Yes.
Okay. Okay. So what do you mean by this, that when he patient started having trouble initiating walking, especially on waking up in the morning?
So when patient says when he wakes up in the morning while putting the foot on the ground, he feels that feet are stuck to the ground. And this is not disabling. He can manage on his own, but he feels initially
What
only at the
is
initiation of
called
gait.
as stuck to the ground?
So it will be, ma'am, it could be either apraxia because it occurs only at the initiation of gait. So gait apraxia, or it could be freezing of the gait. So freezing episodes. Either
Yeah.
of.
So in usual terms, we will say freezing of gait.
Yes.
Okay. Now it has happened because of gait apraxia or because of something else that we'll see. But it is freezing of gait.
Freezing of the gait. Yes.
Okay. But what is the importance of waking up in the morning and then is he not having this freezing any time else?
So, ma'am, he would feel, but it would be especially more in the morning. That's
Okay.
what he would describe.
Okay. So, which are the conditions where you can have some diurnal fluctuations in the Parkinsonian symptoms?
Ma'am, in the idiopathic PD itself, patient can have diurnal fluctuation. In the diffuse
No, diurnal
Lewy body disease.
fluctuations in the PD symptoms, not the cognition. I'm not talking about cognition part. I'm saying PD symptoms, the gait difficulty or the dystonia, all these things. There can be a
So,
diurnal
ma'am,
fluctuation in
especially
certain
after
conditions.
only after initiating the levodopa therapy, the dopaminergic replacement therapy, patient could have on and off periods, and accordingly, patient can have fluctuations.
Okay.
So,
See, but
Uh,
I'm talking about diurnal. So it is like morning better, evening worse, something like that. Some
I'm not aware of
extrapyramidal
that.
syndromes are there which can worsen in the evening time. In the morning time, they are better. Which are those?
Sorry, I'm not aware of that.
Okay, so it is usually DRD or PARK2,
Okay, okay.
Parkin mutation. Okay, so
Yes.
they have a lot of sleep benefits. So early in the morning, they are much better. As the
Hmm.
day progresses, the Parkinsonian symptoms, the dystonias also can worsen.
Yes,
Okay,
ma'am.
yeah.
Hmm.
So this patient, first of all, this is not sundowning. This is opposite of sundowning. This is benefit, and then evening, morning they are much better. That is sleep benefit we call it. So till 2 o'clock, 3 o'clock they are better. Then by afternoon or evening they start worsening. This is not cognition sundowning. This is the worsening of Parkinsonian syndromes, Parkinsonian symptoms basically. Okay,
Okay.
DRD and PARK2 mutation that you should remember. These two have significant diurnal fluctuations. Okay. Then so for patient
Okay.
started noticing gait freezing, which is there since past 5 to 6 months.
6 months,
Okay.
yes.
Yeah. Then so you
Uh,
mentioned that there are certain he improves. Patient could manage to walk with some cues. What do you mean by that?
So, ma'am, with some cues, he would be able to, meaning if he targets on the step and if he targets on the, uh, if he focuses on the next target that he has to take, then he
Hmm.
would find it little, he would be able to go through that. So, that is basically that suggests the cortices are okay, like supplementary motor area and the visual cortex. They especially help with the cues.
Hmm.
So it suggests that they are usually the frontal premotor cortex, SMA, and the visual cortex is usually okay. And the problem points more towards the striatal dopaminergic deficiency or basal ganglia disorders.
Yeah. So, but did they give that history that he is improving with cues like that?
Yes, yes, ma'am. He himself said that with
What did the
visual
relative
cues.
improve? Hmm?
Sorry, ma'am.
What did the relative say, or he said that about the?
He said that
Hmm.
whenever he gets stuck, he would
Hmm.
target on his feet and he
Hmm.
would target on the next step that he has to take. And
Hmm.
then he would be able to take himself through that. So,
Okay.
like that, he described that.
Okay. So, can you just tell me what are the ways to overcome the gate freezing with the
Uh,
cues? Which are the cues, different types of cues that have come now to improve the gate
so, ma'am,
freezing of gate?
gate freezing cues can be like musical cue can be there,
Hmm.
auditory, sensory cue could be there.
Hmm.
Then we can say 1, 2, 3, 1, 2, 3, and ask the patient to focus on the
Yeah.
step while counting 1, 2, 3 and ask them to take a step ahead.
Yes.
Then we can have like a striped floor. On the striped floor, they
Yes.
usually are better.
Yeah.
And yeah, ma'am.
So visual cues are there, auditory cues are there.
Hmm.
What do you mean by sensory cues?
Sensory is, ma'am, visual or auditory cues or tactile could be tactile cue also.
Which tactile cues? Can you elaborate on that?
Uh, no, ma'am, I'm
So nowadays they are coming up with the vibratory
like
bands.
vibratory.
Yeah,
Yeah,
they
yeah,
have come up
yeah,
with a vibratory band.
yeah,
Okay, so
yeah.
it senses as soon as the patient is freezing. It
Hmm,
senses the patient's gait has slowed down. Okay,
hmm,
and the
hmm.
speed has slowed down. So it just senses that and it starts vibrating. So that acts as a cue. So that is sensory.
Yes.
That is vibratory cue. Okay.
Hmm.
Okay, so you mentioned visual hai, auditory hai, vibratory cues are there, and also that is like walking stick with the laser that you use. That is very commonly being used. Okay,
Yes.
yeah.
Hmm.
So these are the visual cues. So what do you mean by visual gait improving with visual cues?
Uh, Meaning that, ma'am, it is
Hmm.
more of an extra pyramid, meaning more of a basal ganglia or brainstem problem rather than the frontal cortex itself.
Cortical
Because
problem.
if
Yeah.
yes,
Hmm.
so if patient is cognitively okay, he should be able to walk with the cues, and that suggests that that this freezing is not because of the gait apraxia. Gait apraxia usually doesn't improve with the visual cues. It's usually the extrapyramidal gait disorder which improves with
No,
the.
gait apraxis also can improve with the visual cues. Okay.
Okay.
It just indicates the cortex is paired and it's mainly involvement of the basal ganglia circuitry.
Basal ganglia, yes.
Okay. Then next
And
slide.
yeah, patient has history of softening of speech and reduced speech
No,
volume
here
for
you
past.
mentioned that patient started having the difficulty in turning and it becomes slow and imbalance worsens while turning.
Hmm.
Okay. And then there is difficulty to navigate through the narrow
Narrow
passages.
passages, yes.
Yeah. What do you mean by this now? That he has started taking short steps and all?
So, ma'am, when he goes to the crowded place or it is a narrow passage, then especially he starts taking cautious gait. So that is more of an adaptation issue, and that meaning the postural response to the environment is defective, and that
Or
usually.
it is becoming like Parkinsonism itself has started to become short steps now. Short
But ma'am,
steps, narrow
it does.
base.
Yeah, but ma'am, it doesn't happen on the when he's at home or when he's walking on the even surface. This especially becomes more apparent when he goes through all these obstacles or he goes to the unpredictable, uneven surfaces or crowded places.
But this entire sentence that he has become, he has some difficulty in manipulating his way through obstacles while
Hmm.
walking on uneven surfaces or
Hmm.
in crowded places. Okay,
Hmm.
so all this history can also come, and narrow passages. All this
Hmm.
history also can come in ataxia.
Yes, ma'am. So, ma'am,
Understand?
that's why
So you want
he
to say
denies
that he
any.
has become ataxic? See,
Ma'am, so he
why
denies
do
any
these
swaying.
patients, one minute,
Hmm.
why do these patients start having difficulty in walking through the narrow passages or uneven surfaces?
So, ma'am, that is more suggestive of adaptation issue. That
No,
is the
no, no, no,
postural.
no, no, no,
Yeah.
no. Adaptation issue nahi. We are talking about why do they start having difficulty in walking through the narrow passages? That means patients inherently the base has become broad. Okay, so if they are
Hmm.
made to walk on a narrow base, they start having imbalance.
Hmm.
Understand? So that means you
Yes.
want to convey that the base has become broad because ataxia, everything like except for PD, okay, everything else tend to have a broader base. All other atypical Parkinsonian gaits tend to be a bit wider base.
Okay, ma'am. Yeah.
Understand? So you
Yes.
want to say you want to point towards that this is something likely to be more of atypical Parkinsonism rather than a typical Parkinsonism.
Uh,
Okay, and there could be a combination of ataxia also in this, from your history at least.
okay, ma'am.
Okay, so the
Yes.
typical extrapyramidal imbalance, they give the history that they are falling when they are wearing clothes, they are falling backwards. When they are getting up from chair, they are falling backwards. When they are sitting in the
Hmm.
bathroom, washroom, they are trying to get up, they are falling backwards. Or
Hmm.
typical
Hmm.
PD, they are trying to fall forward. They tend to fall forwards. Okay, but in
Hmm.
your
Hmm.
history, this history or walking imbalance, walking on uneven surfaces, imbalance walking in narrow passages or crowded passages, that means their base has become broad and they have to narrow their base. Understand? And if they are made to narrow their base, they are worsening on imbalance.
Okay, ma'am.
Understand? So this is
Yes,
another
ma'am.
point which is pointing towards that this could be an atypical Parkinson's.
Okay, ma'am.
Okay,
Okay.
then
Hmm. Then patient has history of softening of speech and reduced speech volume for past 3 to 4 months, which has been progressive so far. Initially, it was comprehensible to others, although now occasionally becomes incomprehensible to relatives as well. Although patient does not have any difficulty in understanding, reading, or syntax formation while writing. Although his handwriting has changed over past 3 to 4 months in the sense that it has become smaller, and checks tend to get bounced due to the change of signature. And at
okay.
present, patient is functionally independent for all his
So
basic
when
activities of.
you want to describe the history of speech, okay, what do you convey from this history?
So, ma'am, this is not a language issue, primarily speech
Okay.
issue, and it becomes incomprehensible to relatives with the softening of speech. So it is both the pitch is also low, and it could also be dysarthria, like consonants also could not be clear.
No, the pitch
So
nahi,
this.
it is the volume that has lowered down, right?
Yes, ma'am.
Okay, so there is a hypovolemia of speech.
Hmm.
Okay. And what else is there? Is he talking in a a faster way, or he's
No,
talking in
ma'am.
slow way?
I asked for the fascination, but they didn't give any history, ma'am, of fascination. He doesn't speak fast. He speaks
Fascination.
at
I'm
normal
also
pace.
talking about whether there is a tachyphymia. Is he jumbling with two, three
Tachyphylline,
words together?
no, it's not there, ma'am. He
Okay.
speaks at a normal pace with a
Hmm.
uniform pace without any fluctuations or irregularity in the volume,
Hmm.
and it is
But it is
uniformly
consistently
reduced.
reduced volume.
Yes, yes.
Okay. What about the whether it is monotonous? What about the prosody?
So it is monotonous, ma'am. Yeah, it is
Okay.
monotonous.
But along with when you're describing the speech part, you have mentioned it correctly that there is no language issue because
Hmm.
that you convey from that history that he has no difficulty in understanding, reading, and writing, etc. Okay. But when you are coming to speech part, you also similar in the same paragraph you can also mention whether there is any swallowing difficulty or whether there is any grunting while sleeping.
Okay, ma'am. Okay.
Okay.
Yeah.
So it covers the all the bulbar part. Okay.
Yes, ma'am.
Yeah.
Yes.
Okay. Then.
At present,
There
patient
is
is
no
functionally.
so there is no coughing while swallowing and no stridorous
No, no,
breathing in
ma'am.
the sleep. Okay.
No. Yes.
Then
At present, patient is functionally independent for all his basic activities of daily living. He looks after his business and actively takes part in financial management as well. He walks around without support and has no history of falls so far. Should I go ahead, ma'am, with the negative history?
yeah, yeah.
So patient has no history of cognitive decline, headache, loss of consciousness, vomiting, seizures, hallucinations, or behavioral changes. No history of any cranial nerve involvement suggestive of anosmia, hyposmia, visual impairment, dizziness, hearing loss, difficulty in chewing or swallowing. No history of sensory disturbance or coordination impairment. No history of any sort of involuntary movements. No history of abnormal sweating, bloating, postprandial fullness, diarrhea or constipation, palpitation, blackouts, and no history of abnormal sleep behavior, that is any dream enactment behavior or parasomnias.
When do you call somebody starts having abnormal sleep behavior? What do you want to convey by this history?
Also, ma'am, specifically because the history suggestive could be suggestive of the extrapyramidal syndrome. We would especially want to ask for the RAM behavior disorder to
So
look for any evidence of
what is
synucleinopathy.
the typical history that you ask for the REM behavioral disorder?
So violent or aggressive movement during sleep, or
No, but
any vocalization during sleep.
no. So you want to ask like you want to ask few more questions to know whether it is a REM behavior sleep or not, right? You
Okay.
want to ask some more questions because there are many parasomnias. Like they can be NREM parasomnia, there can be REM parasomnias. So how do you know
Yes.
that this is REM parasomnia?
So, ma'am, after around 90 minutes of sleep,
After two to
usually
three hours. Yeah.
2 to 3 hours.
Huh.
Okay.
After 2 to 3 hours of sleep, you start having
Hmm.
this involuntary these movements. Okay.
Hmm.
And
Hmm.
these movements they resemble what? They are anything like like picking on clothes or something like that, or something more happens in these movements.
Violent, aggressive behavior, ma'am,
Violent,
with the
aggressive. They are,
and the partners could get hurt in the process, or the patient themselves can get hurt during
yeah,
the process.
it is
Hmm.
enactment of dreams. So that
Hmm.
history has to come. You have to ask them whether they get dreams.
Yes, ma'am.
Okay. And
Hmm.
when the relatives also you can ask if you feel that they are like enacting that dream, the relatives will be
Hmm.
able to tell.
Hmm.
It is very classical of RBD that
Yes.
one that it should happen like after 2 to 3 hours, not immediately after falling asleep.
Yes.
And it should be associated with enactment. The relatives will be able, patient will also be able to tell that he gets dreams. Okay,
Hmm.
and the relatives
Hmm.
will be able to tell that he's acting out his dreams.
Yes.
Okay, so that is the in which conditions you get this type of REM behavioral disorder.
So alpha synucleinopathy, ma'am, primarily Parkinson's disease, multiple system atrophy, diffuse Lewy body disease, and also in uh, one type of PCAN, which is mitochondrial.
Any other condition which is acquired and you get lot of REM behavioral disorder.
Eglon 5, ma'am,
And?
IGLN 5,
And
and
similar, one more autoimmune condition. Casper 2.
NMD,
I
Casper.
mean
Okay.
LGI.
Yeah. Okay.
Okay. So these conditions you can have a lot of REM behavioral sleep disorder.
Okay.
Okay. So what is the difference between NREM sleep parasomnia and REM sleep parasomnia?
So in NREM sleep parasomnia, ma'am, usually they have confusional arousals with they have sleep terrors, and
Most
usually
important is what? Most important is what? First thing you will ask if they remember the dream or not,
they
right?
remember. So they remember the dreams in REM. They don't remember it in NREM.
Correct. And what other NREM parasomnias are there?
There is eating disorder, sleep-related eating disorder, sleep-related sexual behavior disorder,
Huh.
and sleep talking and sleepwalking. That is somnambulism or sleep eating,
Somnambulism, yeah. Then
and sleep terrors.
sleep terror, night.
Usually, nightmares are more part of REM, and sleep terrors are
Night
more
terror.
part
Huh.
of NREM.
Yeah. Sleep terrors, basically sleepwalking,
Yes.
sleep related eating, sleep terrors. Okay, sexual parasomnias. Okay,
Yes.
sexual behavioral disorder. Okay, okay. So, and then any other condition where you get REM behavioral disorders like this? And what is the treatment, first of all? What is the treatment for this REM behavioral
So,
disorder?
ma'am, for if patient has RBD, we can give either clonazepam or melatonin, which is
Okay.
the
And what is
proven.
the localization for abnormal this REM behavioral disorder?
So, ma'am, mainly it is in the dorsolateral nucleus of the midbrain.
No. Then I have to go into the sleep cycle. I have to ask you the sleep cycle then. Where is the localization of sleep RBD?
Uh,
REM sleep basically. Pons. It is pons.
Pons. Yeah, yeah,
Okay. And which
yeah.
nucleus in pons? Which is a norepinephrine releasing?
Or raphe nucleus.
RAF nucleus.
That is serotonergic. Sorry.
Yeah, that is serotonergic. And one more is there, no?
A locus
Locus
ceruleus.
ceruleus.
Yeah,
Okay.
yeah,
Locus
yeah.
ceruleus. Yeah.
Hmm.
Okay.
Hmm.
Yeah. So that is the thing. You should know everything about this RBD because that is asked
Yes.
very frequently.
Yes, ma'am.
Okay. And you mentioned about abnormal sweating, bloating, postprandial fullness. All this is for what?
For to rule out autonomic symptoms, ma'am. To rule out
Which condition
dysautonomic.
you can get this type of autonomic symptoms?
So, ma'am, usually atypical Parkinsonism, MSA, we can get MSAP or MSAC.
Yeah, it's like even the synucleopathies. It is
Hmm.
synucleopathies which can get the autonomic dysfunction, and it is usually central autonomic dysfunction,
Hmm.
right? So,
Hmm.
what is the difference between central and peripheral autonomic dysfunction?
When central autonomic dysfunction usually is because of the involvement of insula or hypothalamus, and they are usually associated with a lot of sleep related, eating related disorders. Whereas
Hmm?
others, ma'am, I'm not aware of that.
No, so normally symptom for the history also you should know what history will you ask for the central and what history will you ask for the peripheral autonomic dysfunction, right? Okay.
Yes.
What
Hmm.
will you ask for PNS, peripheral autonomic dysfunction?
So, ma'am, we'll ask for the all these things: abnormal
See, the
sweating, bloating,
sweating
post
abnormality is
sweating.
mainly
Yes.
sweating, cold, clammy extremities.
Yes.
Okay,
Hmm.
abnormal sweating
Hmm.
pattern in the extremities, that is for
Hmm.
peripheral.
Hmm.
Then the skin discoloration in the form of shiny skin appearances. Okay,
Hmm.
loss of hair in the peripheral distal parts. Okay,
Hmm.
so that can happen because of the peripheral autonomic dysfunction. Trophic
Hmm.
changes basically.
Hmm.
Okay, these
Yes.
are the mainly for the peripheral autonomic, but in central you get all these symptoms where you have blackouts on standing.
Hmm.
That is very classical because of postural BP drop. Then gastrointestinal autonomic and urinary autonomic symptoms. So bowel
Hmm.
bladder, it can be anything. You can get constipation, you can get urgency. Okay,
Hmm.
even in the urine, it can be urinary retention or it can be urge incontinence. Both can happen in the autonomic.
Oh,
Okay, you
yes.
cannot determine from the history whether it is from the history. You can know ki if this is UMN, but in autonomic, it can be any of this. Okay.
Yes.
Yeah. So, which are the central autonomic involvement conditions or central causes
Uh,
of dysautonomia, basically, that you mentioned already? MSA, then you
MSA, yes, ma'am.
PHBD,
Pure.
conditions.
Even my Parkinson's disease, MSA, then shy-dragged,
Yes.
then any stroke or myelopathy can give.
Myelopathy, yeah. Cervical cord, in traumatic cervical dorsal cord
Hmm.
myelopathy. Then
And congenital cause like Rett syndrome.
any other
Hmm.
common you can tell, no? What about autoimmune encephalitis? Do you not get autonomic disturbances in that?
Yes, ma'am.
So where are they
So
coming?
primarily involving the
Central.
brainstem
Yeah.
encephalitis are
Yes.
MAR2 and MAR2 encephalitis.
Thalamic areas getting involved, especially hypothalamic areas. Okay.
Yes.
Yeah. Okay. So then tell me now peripheral conditions where you get autonomic dysfunction.
So, ma'am, it would be primarily the peripheral neuropathy,
Hmm.
like autoimmune or amyloidotic or genetic immune neuropathies,
Hmm.
and uh,
Metabolic
MS, yeah,
neuropathies like
diabetes.
diabetes.
Yeah.
Yeah. Yeah. Okay. And what about what is pure autonomic failure then? Is that a central or a peripheral?
Ma'am, that is considered as central disorder.
Yeah. No, it is peripheral. Pure autonomic failure is
Anti
dysautonomia, pan
anti
dysautonomia. It is
ganglioside
peripheral.
antibody. Yeah.
It is peripheral.
Okay.
Okay.
Okay. Yeah.
Yeah. So these and in autoimmune encephalitis or direct brainstem encephalitis, which are the conditions where you can get prominent autonomic dysfunction?
Ma'am, in NMD encephalitis, it would be
You
primarily
can get then.
dysautonomy.
Mhm. Any particular paraneoplastic encephalitis where there is significant autonomic dysfunction can be there.
Anti-WHO antibody, ma'am, HU antibody.
It causes rhombencephalitis. Huh? It causes
Anti,
rhombencephalitis basically.
uh,
It is
ma'am, MAR2, MA2
yeah.
and anti-HU
Okay.
antibody.
Yeah, Vatu. Yes.
Hmm.
Okay. Okay. So
Okay.
why did you ask for this involuntary movements?
Ma'am, any kind of tremors or my to rule out any kind of tremors, myoclonus or any abnormal posturing, which could
See,
add to the.
yeah.
Yeah.
Okay. So in here, what you have mentioned, it is when you are asking in the history taking, you go for the positive history.
Hmm.
Then negative history for localization. Localization means any other system that is affected besides this extrapyramidal system.
Hmm.
Okay. So in that you can ask if there is any cognitive decline, okay, or behavioral changes, okay, or
Hmm.
seizures. But this
Hmm.
headache, loss of consciousness, vomiting, and all this doesn't headache, loss of consciousness, or all doesn't fit into this, right?
Yes.
If you are talking about a degenerative condition
Hmm.
that usually
Yes.
comes in the etiological negative history. Okay.
Yes. Hmm.
So cognitive decline or behavioral changes or seizures, etc., is fine. Then there is
Hmm.
no involvement of any cranial nerves.
Hmm.
Mention like that. So then there is you don't have to mention separately the anosmia, visual impairment, dizziness, hearing loss, like that.
Okay, ma'am.
Okay. Why did you
Hmm.
specifically ask for anosmia?
To look for any early non-motor symptom, ma'am, which would point towards the alpha-synucleopathy.
So for how many years before this anosmia begins actually?
So, ma'am, it can precede as long as 40 years, 30 to 40 years before the
Usually they have mentioned for
actual.
20 years.
Okay.
Okay. And what is
Okay.
Bragg staging?
So Bragg's grading is, ma'am, there are usually four grades. Grade one is it's basically for the localization of the symptoms. So it starts from the peripheral nerves and olfactory pathway and brainstem. Then it involves the vagal nuclei. Then in grade two, it involves the subcortical structures, and in grade three, it involves the neocortex. So
Okay.
it is the progression of the extrapyramidal syndrome we can predict from the Bragg staging.
Okay. Okay. We can move. Why did you ask for the sensory disturbances?
Ma'am, just for the to rule out any other
20 years. It is
neurexis
20 years.
involvement.
Somebody's asked here. How many years? It is 20 years, anosmia. It can begin 20 years. Same is for REM also. REM can begin about 10 to 20 years prior to the Parkinsonian symptoms. Okay.
Okay.
Yeah.
Should I go ahead, ma'am? Hello?
We can move to next slide.
Yeah, yeah. He has history of significant unintentional weight loss around 14 kgs in past 1 year. That is, he has gone from 85 kg to 71 kg with normal appetite without any swallowing dysfunction. No history of other systemic symptoms and no history of exposure to any antipsychotic, antacids or toxins. Family history is not significant, and he is vegetarian by diet. He has regular bowel movement without any constipation. He has history of urinary frequency for past 6 months, and he has normal sleep latency and duration without any abnormal sleep behavior. No history of any high risk behavior or addictions.
In urinary frequency, what do you mean by urinary frequency
So he
positive since last 6 months?
Yeah, so he says that, ma'am, he has to go for voiding for at least 15 to 18 times a day, which was not the
How many
case.
times he has to go in the night?
In night, it is, ma'am, around five times, but he can control at night, ma'am. That's what he says. He has urge to go, but he can control, and that way he has sound sleep. But during the day, especially, he says that it's around 15 to 18 times, which was not the case 6 months back. So he has been urologically, actually, he has been evaluated and he has been found to have BPH, benign prostatic hyperplasia, and he has been on treatment for that.
No, but what is the typical symptom of benign prostatic hyperplasia?
So, ma'am, they have actually urge incontinence
No,
along with the
no, no, no,
frequency.
no, 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 no. So, if you have a benign prostatic hypertrophy, it is outflow obstruction. Okay, so they have symptoms of outflow obstruction, which are hesitancy and poor urinary stream.
Okay.
Okay, and incomplete evacuation. They might feel
Ah,
that thoda is remaining behind, the urine is
hmm.
remaining behind. But most
Okay.
important symptom is either hesitancy or they have a poor stream. Poor
Hmm.
stream clinches the diagnosis. So we will know whether it is because of the prostate or it is a part of little bit Parkinsonian, as a part of Parkinson syndrome.
Okay, ma'am.
Okay, so that you have to ask whether the poor stream is there or it is just frequency or is there any urge incontinence, like he cannot control and he passes the urine.
Yes.
Okay, we have to ask that history.
Yes, ma'am.
If it's a Parkinson's disease, where do you think is the localization for bladder involvement?
Uh, Ma'am, it's a pontine micturition center, which is brainstem would be the localization.
You want to say it's a pontine micturition center involvement or any other localization you want to say? Why can't it be autonomic?
Yes, ma'am, it can be. But,
Okay.
ma'am, in classical PD, I mean,
No,
we
in
asked.
classical PD, you won't get, in typical PD, for example, you
Hmm,
won't get autonomic involvement early.
hmm,
Okay. But from your
hmm.
history itself, it doesn't look like that it might be going towards the typical
Yes, yes.
PD. Okay.
Hmm,
So then you
hmm.
have to mention this, that
Yes,
this could be another possibility for the bladder
yes.
involvement rather than
Okay.
pontine center getting affected. Okay.
Yes, yes.
Okay.
Treatment history, patient has not been initiated on any treatment for the neurological symptoms as such. Is a known case of diabetes mellitus, hypertension, and ischemic heart disease for which he is on treatment.
Okay. Okay. So summary.
77 years old, right-handed male presenting with history of insidious onset progressive pure motor syndrome, that is with gait slowing with possible freezing episodes and softening of speech and possible micrographia without any higher mental function, cranial nerve, sensory coordination, involvement or involuntary movements, with history of significant unintentional weight loss without other systemic symptoms.
Okay. So what is the structural localization for this?
So, ma'am, I would like to localize because the freezing, especially because it's improving with the cues. I would like to assume that the supplementary motor area and prefrontal motor cortices are working fine. So, I would like to localize it to striatum and its connections.
See, in your summary, what you have mentioned that there is a history of insidious onset progressive pure motor syndrome. Okay.
Yes.
So rather
Yes.
than that, now you know from your history there is no cerebellar ataxia. Okay. Now you
Yes,
know
ma'am.
from
Yes.
your history there is no sensory ataxia.
Hmm.
Okay. Now you
Hmm.
know from your history that there is clear cut history that there is a freezing happening, which doesn't
Hmm.
happen in any other condition.
Yes, ma'am.
Okay. So you
Hmm.
can say that this is insidious onset progressive symmetrical
Hmm.
extrapyramidal syndrome. You didn't give any history of asymmetricity.
So, ma'am, I only had one doubt.
You mentioned that history that little bit left more than right you mentioned, but not much.
Yes,
Okay, it's
that is
like
the only
it did
thing.
come
Yeah.
as the right hand became stiff or anything. Okay,
Yes. Yes.
so you have to say it is incidence onset, gradually progressive, symmetrical extrapyramidal syndrome. This is extrapyramidal syndrome because
Yes.
you have that gait freezing.
Hmm.
That history is very prominent, even though he
Hmm.
has not fallen. He is now 8 9 months into the disease. He has not fallen, but it is the freezing doesn't happen in any other neurological condition.
Yes.
Understand? So you have
Yes.
to say that this is a extrapyramidal symmetrical extrapyramidal syndrome associated with early
Hmm.
gait freezing. It has started quite early,
Okay.
with early gait freezing,
Hmm.
with hypophonia,
Hmm.
with micrographia. You can mention. Well, he did tell himself that the handwriting has changed. He told
Yes.
he
Yes,
told
ma'am.
the handwriting has become smaller.
Because he writes actively, used to write actively for the business purposes.
Hmm.
So that he has told it was his chief complaints, one of his chief complaints that for past 3 to 4 months his handwriting has become smaller.
Okay, without any falls as of now.
No falls so far, ma'am.
Okay,
Yeah.
with
Hmm.
bladder involvement,
Hmm.
with
Uh, yeah,
intentional weight
ma'am.
loss.
Okay.
Okay,
Yeah.
because 15 20 times in a day is not normal. 5 to 6 times
Yes.
is not normal. Forget about daytime,
Yes.
but in the night time, if you have 5 to 6 times urinary urge, then it is not normal. So you have to include that in your summary itself.
Okay, ma'am. Yeah.
Okay. So now
Hmm.
you can say now it is like extrapyramidal syndrome with involvement of basal ganglia and its connections.
Hmm.
Okay. Where
Hmm.
is this writing problem coming from?
So, ma'am, writing problem could be the could be suggestive of the bradykinesia of the
Yeah.
hands. That
Yeah.
is extrapyramidal one.
Yeah. When you go back to the history of first slide, just can you go back to the first
Yes.
slide where you have mentioned the writing difficulty and all?
Writing difficult here, ma'am.
Hmm. So when you mentioned that you started off the history with the gait difficulty, gait slowness happened, then gait freezing, you came to gait freezing. Okay.
Hmm.
Then you
Hmm.
came that there is difficulty walking in the narrow passages.
Hmm.
Okay. There is a turning difficulty that you mentioned.
Hmm.
Here in this paragraph you can also mention if there what is the base of the gait. Okay, many
Okay.
times relatives will be able to tell that he walks with feet wide apart or feet close together.
Hmm.
Okay, so that one point you can mention here, the base of the gait, many times they'll be able to tell.
Okay.
Okay, you can also tell whether there is increased arm movements while walking and
Yes.
less leg movements.
Yes.
Okay, some patients might know, relatives might notice, so even that you
Hmm.
can mention here.
Yes.
Okay,
Hmm.
then third, one more important thing in the writing part, you have to ask whether beginning of the writing is small or the end of the writing is small or throughout the
Uh,
writing is small.
Throughout it is
Why
small,
am I
ma'am.
asking for this?
Because in idiopathic PDH is usually it becomes slower at the end of the by the end of the sentences or by the end of the paragraph, it starts becoming smaller.
In which
And
condition?
in idiopathic PD, ma'am.
Usually, yeah. Usually it is from the beginning only. It is small. Okay.
Hmm.
Yeah. So when one point of differential, when they mention, when you start drawing a Archimedes spiral, okay, for example, initially the spirals are very tightly packed, and then they
Hmm.
open up, because in the beginning there is significant that stiffness and rigidity, and with more and more movement, slightly it reduces. So the circles become bit wider. Okay.
Okay.
So in the
Huh.
even Parkinson, it's like that. So in the beginning there may be much micrographia. Little bit later it might improve.
Okay,
Whereas
ma'am.
in dystonia, what happens in the beginning, the writing might be normal, but as the paper the writing progresses, it becomes more and more dystonic and bigger in size.
Okay.
Okay, and what happens in the cerebellar writing?
They are uniformly, there is micrographia,
Yeah,
larger
that's the
handwritings.
difference between dystonic writing and
Hmm.
cerebellar writing. So dystonia, in the beginning it might be normal, later on it becomes bigger and bigger.
Hmm.
Whereas in cerebellar, in the beginning, from the beginning only, it is larger writing, and it is not on the line. So it can be like above and below the line, and some letters might be small, some might be bigger. Even that can happen.
Yes.
Okay. Yeah. So
Ma'am,
that
I
is
had just one doubt that how we get decremental bradykinesia in the extrapyramidal syndromes, especially the PD. The it is
okay.
akin
That
to
is the
that
one of the differentiating point between the typical PD and atypical PD, right? So
yes,
in
yes,
typical PD, you have a decremental bradykinesia,
yes,
decremental the finger tapping and all.
yes,
Okay. Whereas in atypical PD, from the beginning only, it is in the lower volume and lower amplitude.
yes, ma'am. So,
Okay.
ma'am, does it happen? Does the same happen with the handwritings as well?
Yeah,
That
yeah,
they are initially
yeah.
they are better in PD and then they become micrographic as
No,
patient
writing
can.
no, writing is slightly different from that.
Okay, ma'am.
Writing is not a repetitive activity.
Huh,
Okay.
okay. Hmm.
So in the tapping, it's like a alternate repetitive activity of the fingers.
Huh, yes.
Okay, so that is why it causes decremental. Whereas in PD, usually in the beginning, it is very stiff. The hand is
Hmm.
very stiff. So in the beginning, it might be very small, and
Okay,
even the circles might Archimedes spiral might be very compact in the beginning, and later on it widens.
okay, okay.
Okay, so that is one thing. Then when you have mentioned the gait in the beginning, you have mentioned entire thing about gait.
Hmm.
Okay, then you have mentioned the like how he walks and turning and all that, but till now, luckily, fall has not happened.
Hmm.
Then, then you have come to speech, and then you have come to writing. Besides writing, nothing else you have mentioned about the upper body.
So, ma'am, he denies any kind of slowing in the basic activities, like even not even minor slowing. He doesn't. That is the something that is surprising that he denies. I actively ask for that, but he denies any slowing in brushing or cleansing himself up or wearing clothes, eating, anything with upper hands. Other than micrographia, he doesn't have anything else.
So no activity, no slowing in doing the activities involving
No,
upper hand, upper arm.
no,
Like
no.
there is
Yeah.
no slowing while brushing teeth or eating. Nothing.
Nothing, ma'am, nothing.
Wearing clothes. No, no slowing.
No, ma'am. He
Okay.
denies.
So you
Hmm.
want to say that this is much more of the lower body rather than the upper body.
Yes, ma'am.
Okay.
More so. Just upper body micrographia is the only symptom suggestive of some hand involvement, but otherwise there is nothing else.
Okay. Okay. So what is your possibility then? Somebody
Then,
has
ma'am,
asked
we can
here.
consider vascular Parkinsonism
Hmm.
with the lower body predominance. Hello,
Go
hello.
back to summary slide.
Yeah, yeah.
Yeah. So now you mention what are the DDs in your case. This is a symmetrical extrapyramidal syndrome characterized by significant gait involvement early, gait
Yes,
freezing, okay,
yes,
and little
yes,
bit of speech and writing involvement. But mainly it
yes.
is gait involvement and bladder involvement and
Hmm.
speech involvement.
Yes, ma'am.
Okay, so what is the possibility that you can consider here?
So, ma'am, I would like to
Which
consider
PD will you
progressive.
consider first?
Sorry, ma'am.
So first tell me which are typical extrapyramidal.
Ma'am, you're not audible.
In the summary itself, you can also mention that this is an atypical extrapyramidal syndrome.
Okay.
Hello. In the
Okay.
localization, you have mentioned extrapyramidal syndrome. Okay.
Yes, ma'am.
But
Yes,
you
ma'am.
can go further ahead and tell that this could be an extrapyramidal, atypical extrapyramidal syndrome.
Okay, ma'am.
Atypical Parkinsonian syndrome, basically, not extrapyramidal. Atypical Parkinsonian syndrome.
Yes,
And then
ma'am.
you can defend your points. So, how do you differentiate? What are the major differentiating points between the typical and atypical Parkinson's disease or Parkinsonian syndromes?
So, ma'am, typical PD would be asymmetrical at onset with marked bradykinesia, and the gait
Atypical
that
at
is
onset and even for a long period of time, at
long
least
period
up to
of time.
5 years, they
Yes,
can remain
yes,
asymmetrical. Okay.
yes,
Then
yes. And if the PD is tremor predominant, then it would be usually accompanied by rest tremors and postural tremors. And if it is gait predominant, patient would have progressive gait freezing, and it would be usually
no.
levodopa responsive.
Just go on telling important points. So one you told
So
asymmetricity.
asymmetrical,
The
levodopa
second is
responsive,
rest tremors.
rest tremors. Yes.
Okay. Third is levodopa
Levodopa
responsiveness.
responsive.
Then
Yes. Uh, then ma'am, mm,
so once this question is asked, you have to just go on blabbering because it has to be in your mind completely fixed.
yes, ma'am.
3 points you mentioned: levodopa responsiveness, asymmetricity, and rest tremors. Further things.
Uh, there would be so in patient would be functionally independent for a longer period of time in PD, whereas they become wheelchair bound earlier in case of atypical PD.
So whatever you have in front of you, you tell. Na? So there is a gait freezing, which doesn't
Hmm.
happen so early in the typical Parkinson's disease,
Yes, ma'am.
isn't it? So it happens in the atypical Parkinsonian syndrome or a kinetic atypical Parkinsonian syndromes.
Hmm.
Okay, so gait freezing and early falls. These are all the features of atypical disease. Then
And ma'am, symmetricity, absence of tremors, poor levodopa response.
symmetricity हो गया, rest tremors happened, then levodopa responsiveness happened. Next point was gait freezing, then
Hmm.
early falls. This is the
Hmm.
difference. Then what else?
So it would be slowly
What is the
progressive, the
okay? I will ask you
idiopathic PD. Yeah.
1 minute. So in the one more thing that is important in your history, you can also I told you that you have to when you're talking about gait, you mention like slowness, this thing, freezing, etc. Then I told you about the base you can mention. Okay.
Hmm.
Sometimes patient will be able to tell. Then you can also tell about posture. What kind of posture you get in
Yes, so
typical
PD patients will have stoop posture, whereas it would be, but there could be postural variability in
yeah, and in some
the
PSPs and also it's
PSP
more
will
of
be
erect
more
posture.
erect,
And
and
knee
MS.
extension will be there, trunk and knee extension. Whereas in
Yes,
typical PD, it is trunk and knee flexion. Okay.
yes.
And sometimes in PISA syndrome, that is tilted, lateropulsion, etc., can be there in MSA.
MSA,
Okay.
Camptocormia and Pisacin.
Yeah.
Yes.
So all this postural differences will be there in typical PD and atypical Parkinson's. Okay,
Yes.
base difference will be there. Narrow base in Parkinson's. The time it is wide based in atypical Parkinson's. Then
Yes.
gate freezing, gate initiation difficulty. Those there are certain terms that is start hesitation. Okay, then freezing of gate.
Yes.
Then what is
So
magnetic gate? What is
fascination is more suggestive of the PD,
yeah?
whereas absence of
Fascination is
fascination
usually
is
not
more
seen
of
in the
frontal
atypical
gate.
PD. Yeah.
Yes. Yes.
Magnetic gate, marche
Hmm.
petit pass. That is usually seen with the
Yes.
atypical Parkinsonian syndrome. Okay.
Hmm.
The upper body movement more than
Yes.
the lower body movement is usually seen. Upper body, I mean, that is usually seen with the atypical Parkinsonian syndromes. Okay.
Yes.
Then,
Hmm.
yeah, so and falls. So by what age the PSP starts falling? By how many, within how many months the PSP start falling?
So PSP could have fall right from the onset, ma'am. And by 3 months, at least
No,
they
no, no.
start falling.
There, the usual onset of fall, the Jankovic has mentioned usual onset of falls in all these atypical extrapyramidal syndromes. So PSP start falling by around what time? Within 10 to 12 months, they start falling, PSPs.
Okay. Okay.
Okay,
Okay.
MSA starts falling when? Usually it is 2.5 to 3 years.
Okay, ma'am.
Okay,
Yes.
PSP is 10 to 12 months, MSA is 2.5 to 3 years. When do the
Hmm.
typical Parkinson's patients start falling?
After 5 years, ma'am.
After 5 years, yeah. Okay, so
Hmm.
can you just tell me what are the gait types of gait disorders?
So, ma'am, gait disorder could be either central or peripheral.
Hmm.
And central gait disorder usually is characterized by freezing of the gait. Whereas
No, see,
peripheral,
central and peripheral won't fall. No, 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 no. What does the Bradley mention?
I mean
Types of
higher
gait
level,
disorder.
mid level,
Ah,
and lower level
yeah, you
gait
have to speak
disorders.
in those terms only.
Yes, yes. So higher level gait disorders are usually due to involvement of the frontal cortex, like in
Hmm.
case of normal pressure hydrocephalus or vascular Parkinsonism. Whereas the mid-level gait disorder, also subcortical disorders like extrapyramidal disorders will be higher level gait disorder, and middle level would be vestibular and cerebellar symptoms leading to the gait disturbance, and lower level would be the
Hmm.
peripheral now, primarily neuropathies,
Hmm. Neuropathy, muscle disorder, or
muscle disorders.
musculoskeletal conditions. Okay.
Yes.
So, what is the hallmark of higher order gait disorder?
So higher order, ma'am, if it is usually it would be a frontal gait. It would they would have bradykinesia only on walking, but otherwise they would not have in the supine position, lying down position.
You
So
mean to
only
say
on
gait apraxias?
gait apraxia, yes,
Yeah. Then
magnetic
which
gait,
other?
gait,
Magnetic gait.
yes.
Then
Um, then ma'am, they are usually their arm swings tend to be normal, and that their gait tends to be little wide based than
yeah,
the
that is
extra
second.
pyramids.
Then
Yes. And the freezing of gait, if at all happens, it does not respond to the sensory cues as much as extrapyramidal does.
that's fine. So this is like freezing of gait. That is the
Yes.
most important thing.
And
Gait,
ma'am,
gait
there would
ignition
only be slowing
failure.
of gait, but there would be no
See,
slowing of the upper extremity or the facial movements.
yeah, when you start a gate, first is initiating the gate. So higher order udari se you start having problems. You have gate initiation failure. So it is
Hmm.
first thing is gate initiation failure. Second
Hmm.
thing is there is when they are walking, there is a freezing of gait. Okay, especially if
Yes.
there are obstacles and all, they will have more freezing of gait.
Yes.
Okay. And then upper body movements tends to be better than the lower body movements. Okay.
Yes. Hmm.
Then you mentioned that on lying down or supine position they are better as compared to when
Hmm.
they are walking. That is like a
Hmm.
gait apraxia.
Yes. Yes.
Okay. And then when they are walking, the foot clearance is very poor. So it is like a magnetic gait. Foot is glued
Hmm.
to the ground. That is magnetic
Yes.
gait.
Yes,
Then
ma'am.
what happens when they are turning? What kind of turning they have?
They have a turn and block, ma'am. So
No.
more than one
N block.
step.
No, 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 no. N block turning tends to be typical PD.
Okay.
N block turning tends to be typical PD.
Hmm.
Whereas in atypical Parkinsonian syndromes, PSPs tend to have pivotal
They
turning.
tend
So
to
they
pivot.
fix on
Yeah,
one
they
leg
tend to
and turn.
pivot. Yes, yes.
Understand? In
Hmm.
PSPs, they tend to pivot on one leg. And if there
Yes.
is symmetrical typical Parkinsonism, like for example vascular or
Hmm.
NPH,
Hmm.
they tend to have piecemeal turning.
Okay. Yes.
Okay. So
Hmm.
that is another term that you get in higher order disorder, that is piecemeal turning.
Yes.
So gate initiation failure, freezing of gate, then there is a piecemeal turning.
Hmm.
Okay, poor foot
Hmm.
clearance,
Hmm.
magnetic gate happened. Then what else you get? Fascination is another characteristic
Fascination.
of a
Yes.
higher order gait disorder.
Yes.
And of course, early postural instability.
Hmm.
Okay. And
Yes.
in that also, if you want to differentiate between the vascular versus uh, NPH gait, how will you differentiate between these two?
So, ma'am, NPH gait would be associated with marked gait apraxia and magnetic
Hmm.
gait,
But even some
wherein
vascular conditions also you can get severe gait apraxias.
uh,
How do you differentiate between them? One is the history that previous strokes are there, and then there is a decline in the gait.
yes, ma'am.
If you
So
don't have that
vascular,
history, then
usually vascular patients tend to have pseudobulbar effect and others symptoms, and they tend to have spastic component to the gait also.
yeah. So they have asymmetrical pyramidal signs.
Hmm.
For vascular conditions, there is one clue to differentiate vascular and NPH is
Hmm.
asymmetrical pyramidal signs.
Hmm.
NPH you don't get asymmetrical pyramidal signs.
Yes.
Asymmetrical matlab they can be reflexes becoming brisk on one side, plantar becoming extensor on one side because of course they're old strokes and all. Okay.
Hmm.
Whereas in
Yes.
NPH you don't get this asymmetrical pyramidal signs. Another clue is cognition involvement, which you mentioned,
Yes.
pseudobulbar effect and all that. That is like can be seen in the vascular more rather than NPH.
Yes. Yes.
Another clue is
Um, they have more of urinary symptoms in
urinary can
NPH
be both.
than vascular.
Urinary can be both NPH and this thing vascular.
They have stepwise decline in
Yeah, so
vascular.
that is vascular because of from the history that you get to know.
Hmm. Hmm.
Another point is when they're walking. When
Hmm.
they're walking, the NPH people they walk with feet outward deviation.
Hmm. Okay.
Deviation means the feet are outward deviated. Both the feet when they're walking from ankle onwards
Hmm.
they're outward deviated. Okay,
Hmm.
and that doesn't happen so much in the vascular Parkinson.
Vascular Parkinson.
Okay, so that is one more clue to differentiate between the NPH and vascular Parkinson's. So now that
Yes.
we have discussed all of these things, now which one comes in your first possibility?
So, ma'am, this could be one variant of PD, that is progressive gait freezing. It could be
PIGD
a
variant of PD.
PIGD variant. Yes.
Okay,
But,
then
ma'am, in PIGD variant, patient would start falling early, like postural instability
no,
and
so
gait
still eight
disturbance.
nine months is still okay for PIGD to have postural instability. Okay, so maybe after
Okay.
next
Okay.
2 3 months he may start falling. We don't know. Your history is like 8 9 months only.
Yes. Yes, ma'am.
Okay,
It's a
so
very short history.
PIGD variant of PD is okay, fine.
Hmm.
But you can mention everything because you don't know. When you examine, then only
Yes.
you
Ma'am.
will know now.
Yes,
Okay.
ma'am.
So you can mention PIGD variant because there is a lot of gait freezing early.
Hmm.
PIGD variant of PD or
Hmm.
PAGF variant of PSP will be
Of
there.
PSP. Yes, ma'am.
But you can also consider NPH or
Vascular
vascular
Parkinsonism.
Parkinson's.
Yes.
In the PAGF variant of PSP, by now at least little falls should have started.
Yes, ma'am.
Okay, so
Hmm.
and of course we want to see the gaze and everything, so that we will
Yes.
know only from the
Yes.
examination. Okay,
Yes, ma'am.
okay.
Yes.
Then okay, we can go to examination now.
Yes. So, patient is conscious, alert, oriented to time, place, and person, completely cooperative throughout examination. BP is 130 by 80 in supine position with heart rate of 88 per minute and 126 by 78 in standing position at 3 minutes with heart rate of 92 per minute. No evidence of orthostatic hypotension. And systemic examination is unremarkable. Neurological examination, his higher mental function is absolutely normal. His MMSE is 29 by 30 and his FAB score is 16
What
by
all?
80.
Can you go back to first line? This one. So
Yes.
what all other things you can do on bedside for the autonomic testing?
So, ma'am, we can do the Valsalva maneuver.
Hmm.
We can do the hand grip, isometric hand grip,
Huh?
and look for the diastolic BP. Then we can do the uh,
HRDB, no. First you have to tell is HRDB.
yes.
Okay, heart rate variability with to deep breathing,
Yes.
HRDB.
Yes.
If this question and this question is commonly asked in the exam, so what are the bedside autonomic function tests that you can do?
Okay.
Okay, because
Hmm.
this case is not so much autonomic, we'll not go into that because we have to go further. But you
Yes.
have to know at least HRTP you have to mention in the beginning.
Yes. Yes.
Okay.
Hmm.
One is you're checking the supine and standing blood pressure at 1 minute, 2 minute, 3 minute. HRTP is heart rate variability with deep breathing you're going to do.
Hmm.
Okay. Then you can do this one, isometric grip strengthening.
Yes.
Okay. And you
Hmm.
can do Valsalva maneuvers.
Hmm.
Okay. And you can just do general examination of the patient, like pupillary examination, whether there is an excessive sweating or less sweating.
Hmm.
Okay.
Yes, ma'am.
At least these 3-4 things you should know. Okay.
Yes.
Yeah.
Hmm.
Then
Um, higher mental functions normal. His MMS is 29/30. His FAB
so there
score
is
is
no
6.
involvement of frontal lobe, no involvement
Frontal
of
lobe
frontal
or
lobe,
cognition in general. Yes, ma'am.
no frontal lobe involvement at
No,
all.
no, ma'am. No, ma'am.
Okay, no parietal lobe also, no praxis involvement.
Nothing.
Okay, then
Cranial nerves, he has hypomimia and he has, ma'am, I felt Procerus sign was positive. His, I'll be showing the videos in next slides.
okay.
Horizontal pursuits are saccadic, but otherwise saccades are normal. No other extraocular movement abnormality.
What do you mean by
Horizontal,
horizontal pursuits are saccadic means what?
meaning the pursuits are slow, ma'am. This is a very non-specific finding. It can be seen in
No,
old
you want
age.
to say saccades
Otherwise,
are slow or you want to say pursuits are slow?
pursuits are slow, ma'am. So
What do you mean
pursuits
by
are
that?
saccadic.
No, 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 no. What do you mean by pursuits are slow? You are checking slow eye movement only in pursuits. You are moving your finger very slowly in front of the eyes. So how do you know the pursuits are slow? There cannot be slow pursuits.
Okay, ma'am. Okay.
Okay. There
Hmm.
can be only broken pursuits. That's it. You cannot say slow pursuit, fast pursuit. No. You are
Okay.
supposed to check pursuit slowly only.
Okay. Okay, ma'am.
You are
Hmm.
moving the finger very slowly in front of the eyes. Okay. And the eyes have to track that slow moving finger. That is what is
Yes.
the definition of pursuit.
Yes, ma'am.
So if you have any abnormality in pursuit, it is usually broken pursuit. That means they're trying to have a catch-up circuit.
Huh. Yes.
Understand?
Yes, ma'am.
You cannot have slow pursuit. You can have slow circuits.
Okay, ma'am. Okay, ma'am.
Okay.
Hmm.
So you want to say the slow circuits are there or
No, ma'am. Circuits were normal. Pursuits were little slow, but it was
no,
not that
pursuit slow
remarkable.
doesn't happen. Okay. Either
The
he was
pursuits
not
were, I mean, broken. It was, ma'am, we can say saccadic pursuits if pursuits have broken qualities
saccadic
like,
pursuits वगैरह नहीं है. You have to be crystal clear when you're talking. Otherwise you will end up in trouble.
okay, ma'am. Yeah.
Understand? Because
Yes.
you cannot say saccadic pursuits. You have to
Hmm.
say this is saccad and this is pursuit. That's it. Don't go
Okay.
into the hole. Okay.
Okay, ma'am.
This
Yeah.
pursuits you are supposed to check by slow moving eyes, slow moving finger,
Hmm.
eye movements. Understand? And the
Yes,
slowness
ma'am.
can happen only in saccades, not in pursuits. Pursuits can be
Okay.
broken pursuits.
Okay, ma'am.
Okay.
Yes, ma'am.
It could be possible that he is not following your finger.
Hmm. Yes,
That
ma'am.
could be
Got it.
because of cognitive involvement. That's
In,
why I'm asking whether
yeah.
there is any attention poor or something like that. So
No,
then,
ma'am.
if there is
Nothing.
attention
Absolutely
poor,
nothing.
they may not
Hmm.
just initiate the movement fast.
Hmm.
If
Yes,
you
ma'am.
have checked the saccades by Okane and it is normal, that means it cannot be saccadic slowness also.
Okay, ma'am. Okay.
Saccadic intrusion is different from who is this. Somebody who's asked this saccadic intrusion. Okay, saccadic intrusions. When do you say what are saccadic intrusions? Can you give some examples of saccadic intrusions?
So, ma'am,
Hello.
macro square wave jerk or saccadic
Yeah. So
oscillations.
saccadic intrusions is that there are unnecessary saccades coming up. When
Yes.
you are fixating, you are not supposed to get any saccadic movement.
Hmm. Hmm.
Okay. So if there
Hmm.
are unnecessarily saccades coming up in your fixation,
Hmm.
then it is called as saccadic intrusion.
Hmm.
Okay. So there are examples of it. That is square wave jerks. Okay. Then there are micro and macro. That is micro and macro square wave jerks. Saccadic oscillations are there.
Yes.
Okay, then you can get ocular flutter, then you can get
Hmm.
oscillopsia. At least
Yes.
these before you should remember. The difference between the square wave jerks and the ocular flutter is what?
That intersaccadic interval is
Interval.
there in the
Intersaccadic
macro square
interval
wave
is
jerk,
present in the
but
square wave jerks,
that
not
is
there
not
in
there
the
in the
flutter
flutter.
and
Yes.
oscillopsia. Okay.
Oscillations.
Yeah.
Yes.
So when you have eye movement abnormality, you have to be very clear. First, you check pursuit by slow moving finger. Then you check saccades by rapidly asking him to look up or look down, looks right, look left, like that. Okay.
Hmm.
And in
Hmm.
this movement, you see there is slow initiation, and you can see the entire eye moving like that, or
Hmm.
you can see the eye blinking. Then you know that the saccade is slow.
Hmm.
Okay, and if you have just eye movement is happening in pursuit but it is broken, or they are trying to have a catch up saccade, then we can say ki pursuit is broken.
Huh.
Pursuit cannot be slow. Otherwise, you will have to answer me what are the causes of slow pursuits.
Hmm.
Understand?
Yes.
Do you know? There is no causes mentioned for slow pursuit. Okay, because pursuit is supposed to be slow eye movement.
Hmm.
Okay.
Yes.
Okay. Then
Vertical extraocular movements are normal, and both horizontal and vertical ocan are intact.
hmm.
Pupils are bilateral equally reactive to light. He has hypophonia, low pitch monotonous speech, and no facial weakness or sensory loss, no hearing loss. Gag is normal. Jaw jerk is just present. On motor examination, the muscle bulk is normal. Tone is grade 2 rigidity in all four limbs, bilaterally symmetrical without any cogwheeling. And there is some axial rigidity which is not as remarkable as the
so it
appendicular.
is, yeah. So you have to always mention that which is more limb rigidity is more or axial rigidity is more,
So limb is more than the axial rigidity.
because usually atypical Parkinsonian syndromes they tend to have axial rigidity more
Axial
than
more
the
than
limb
the
rigidity.
appendicular. Yes.
Okay, so that will help you come towards your own diagnosis. Okay,
Yes. Yes.
yeah. Then
And he has mild asymmetrical decremental bradykinesia in both upper limb and lower limb. And he has
how
mirror
do you check
movements.
the lower limb bradykinesia?
So I asked for the leg agility. I looked for the leg agility and the
What do you
foot.
mean by leg agility?
So, ma'am, leg agility is basically the rhythm and the speed of the lower limb,
So how do you
which could
check
be
it? Just
affected
tell me
in
that,
the.
na?
So we asked the patient to tap the whole foot up
Yeah.
and down.
So foot tapping, that is called as foot tapping, and from the
Yes.
ankle.
Yes.
Okay. From the
Hmm.
ankle, you do the foot tapping, keeping the
Yes.
knee extended.
Hmm.
Okay. From that, you get to know the lower limb bradykinesia. So he has
Yes.
symmetrical bradykinesia of both upper limb and lower limb, according to
And
you.
lower limb. Yes.
Okay. So is it decremental, or you say from the beginning it is only low amplitude?
No, ma'am, it is decremental. So in the video, it might
Okay.
be.
Let us see. Then
Yeah. Then he has mirror movements demonstrable in the right hand. Ma'am, is it of significance in the, like you mentioned
mirror
about the
movement.
mirror movements?
Mirror movements are coming when he's doing lower limb activity or when he's doing
No,
the
upper
left.
limb in the right hand when he is doing the left hand activities, it's coming in the right hand.
So where do you localize this mirror movements?
So, ma'am, usually the corpus callosum or the connection of
Huh?
the two hemispheres and supplementary motor area.
No, where is the localization? Acha, what do you said? That is corpus
The
callosum. You're saying mirror movements
yes,
localization.
yes, ma'am, and the supplementary motor area because it's
Mirror movements.
hello.
Huh.
Yes, ma'am.
Now, which conditions you get very prominent mirror movements?
So, ma'am, we can get it in the corticobasal degeneration or
Hmm.
even Parkinson's patients or dystonia. In dystonia, we get classical mirror movements.
Yeah, yeah. Getting affected. The mirror movements come from the basal ganglia only. Okay, and especially with
Yes.
the atypical ones rather than the typical Parkinson's.
Okay.
Okay,
Okay.
mirror movements tend to be more with the atypical Parkinsonian syndromes, especially MSA and CBGD.
CBG. Yes.
Yeah. Okay.
Hmm.
the sign which we typically demonstrate.
Sorry, ma'am.
Which is that sign? Which is that sign in dystonia? We demonstrate a particular sign, right, to show this
That is
mirroring.
overflow phenomenon.
Yeah.
Yeah.
Okay. Then even in the essential tremors, you can get this mirroring of movements.
Mirror movements. Yes. Yes. Hmm.
Okay.
Yeah. Deep tendon reflexes are bilaterally generalized brisk and plantar bilaterally flexor. Strength is normal in all four limbs. And yes, slightly dystonic
So
posturing
normal,
of fingers.
basically, what you mentioned that usually it is like when the patient, when a normal person, when he does activity with one hand, it is there is a inhibition of the other side that is called as transcallosal inhibition.
Huh.
Okay, so that
Yes.
inhibition Parkinsonian, extrapyramidal syndromes and all. So in them, then that complete transcallosal inhibition doesn't happen, and they start mirroring the movement of the other hand also.
Hmm.
So
Yes.
even if somebody asks you why mirror movements happen, so you can tell as loss of transcallosal inhibition.
Inhibition. Yes.
Okay, then
Yeah. Then he has slight dystonic posturing of fingers on outstretched extremities. I'll
okay.
be showing the videos.
Hmm.
So this is mainly for the to look for the tremors. He doesn't have any postural or rest tremors. He's counting backwards, and along with that also it's not coming out.
The tremors
I
are
hope
not there much.
no, ma'am, not at all. And slightly, ma'am, on outstretched extremities, he tends to have some dystonic posturing of finger, especially the right index finger and
Mm-hmm.
the fingers.
Okay, then
But no tremors at all. And so this is so he tends to get a little like
so what are the
decremental at the
differences between the tremors in typical PD and the atypical PDs? In what all atypical PDs you can get tremors?
so ma'am in the in case of PSP we tend to have more of postural tremors rather than the rest tremors. And in case of
Previously, tremors used to be a red flag for the PSP. Okay. So
okay.
now they have started mentioning you can get little bit of tremors in PSP, but they are mainly action tremors or
Hmm.
postural tremors.
Yes.
And you can mention that in one variant of PSP, that is PSP-P, which
P,
is
yes.
Parkinsonian variant,
Hmm.
you can get rest tremors also.
Yes.
Okay.
Hmm.
Then MSA, what kind of tremors you get?
In MSMM, it would be usually
Action tremors.
the
And they have
action tremors.
associated cortical myoclonus also.
Yes.
Okay.
Hmm.
Then in CBS, you can get
Dystonic tremors, ma'am, or coarse dystonic tremors.
yes. Can you
But
get
ma'am, he
LBD?
in LBD, ma'am, uh, no, ma'am.
DLBD.
DLBD
Yes, you
usually
can
doesn't
get
have.
you get the tremors in DLBD. They are usually action postural tremors. Okay.
Okay. Okay.
Yeah.
Hmm.
Then okay, so
I'll-
that's it. So in this patient, we I don't see any tremors.
yes,
Intentional
ma'am.
component is there.
No, ma'am.
Okay.
It's not there. Yeah.
Okay. Then next.
This is for the mirror movement. Ma'am, should it be taken as a soft sign or we should mention, especially in the view of this history of
Because
questionable
that we in the
extrapyramidal?
beginning when you showed in that video that the right index finger and thumb was going in some dystonic posturing. So I
Hmm.
think it's a significant thing because now here you can clearly see when he's doing some activity with the left hand, the right
Yes.
thumb adducts, okay, and the
Yes.
left right index finger also becomes more dystonic, okay.
Yes, ma'am.
So I think it is an important sign. Then,
Okay. And ma'am, this is for the
but I
leg.
don't see so much of bradykinesia in upper limbs, huh?
Yes, ma'am. That is what he doesn't have much in the.
And lower limb. Is it is always better to make them stand and do the tapping. If they are
Okay.
not
Okay.
able to stand, of course postural instability is there, then you won't do. But otherwise now in this, see, that's what I said, ankle tapping should be done, not like this.
Yeah.
He's from
Yes.
hip
So, ma'am.
only he's tapping.
Yeah, ma'am.
From
So,
hip only he's tapping.
initially did the ankle tapping.
No, but you have to repeatedly tell them, do it from ankle. That's why you can make them stand, then they won't use their hips. Okay.
Okay. Okay.
Yeah.
Yeah.
In the beginning he's doing some foot tapping, but
Yes.
even here I don't see so much of now he's having decremental is there. Yeah.
Yes.
But you didn't, when there was no enough time, later on he started using hips only.
Yes.
Okay, then
Yeah. Um, his sensory examination is normal, coordination is normal, his Romberg is negative. He has pull test on retropulsion. He has 4 steps. He takes 4 steps backwards, but he managed unaided. He didn't fall.
so
I
it's
didn't have to
positive,
catch
right?
him. It is positive, ma'am, but it's grade 1
What are the
positive.
grades of pull test?
So, ma'am, up to 2 steps, it's normal. It's grade 0. Then grade 1 is 3 to 5 steps is
Hmm.
grade 1.
Hmm.
Then grade 2, 3, and 4 is mild, moderate, and severe, meaning patient takes uh,
Hmm. Usually we don't say,
hello,
like we say that
hello.
if 3 to 5 steps
Am I
patient
audible?
manages. Hello.
Yes, ma'am. Am I
Yeah.
audible?
Yeah. So 3 to 5 steps
Ye-
and patient manages, it is grade one. More
yes,
than
ma'am.
5 steps, thoda he recovers, but slight instability is there. That is grade two.
Yes.
Okay. Then
Hmm.
more than 5 steps, but then he falls also. It is grade
Hmm.
three,
Hmm.
and falling like a log is grade four.
Yes.
Okay. Even with the gentle tap, he's falling. That is also grade four.
Yes. Yes, ma'am.
Okay.
Yes.
What is push test?
Push test. I'm not aware of one.
Can anybody answer in the audience? Does anybody know what is push test? So before they came up with this pull test, previously they used to do push. That is from the front. Put a pressure on the shoulder from front or on the sternum from front. Okay,
Okay.
and the
Hmm.
patient used to fall backwards.
Hmm.
Okay, and then they used to catch the but what they noticed the fallacy in this, that one examiner cannot carry it. Somebody has to push from the front and somebody has to stand behind to hold them.
Hmm.
So that's how they came with the pull test.
Pull test. Okay.
Okay.
Hmm.
And those patients with a typical Parkinson's, you can give push from the behind because the center of gravity is more front. So they
Hmm.
then from that they can fall on the front rather than behind. If you give
Yes.
a push from behind.
Hmm.
Okay.
Okay.
Yeah. And why do they fall backwards? Why is there tendency to fall backwards? Any particular reason why all these atypical extrapyramidal syndromes tend to fall backwards?
Because of the axial rigidity, ma'am, the
Axial
the
rigidity
trunk
does what?
cannot compensate for the
No,
lower limb
axial
imbalance.
rigidity does what?
So there is no propulsion movement of the trunk to maintain the
No, no, no.
balance, to
So
compensate for the.
it is something about the center of gravity. So if you, yeah, so that is the answer. Correct answer should be this. That when there is axial rigidity, okay, and there is a retrocolis and all that, in especially in PSP and all. So you get or erect posture happens, okay,
Hmm.
knee
Hmm.
extension everything while walking. The
Hmm.
center of gravity shifts behind,
Hmm.
okay, shift
Hmm.
backwards. So it
Oh,
goes all the way from the back of occiput to the back of heel.
okay.
Okay, so center of gravity has shifted backwards now because of this
Yeah.
actual rigidity. That's
Yes.
the correct answer. That's why they tend to fall backwards. Okay.
Hmm. Yes.
Then can we see the gate?
Yes, ma'am.
Hmm. So can you describe the gait while the video is playing?
Yes, ma'am. So,
Hmm.
ma'am, the patient is having stooped posture. Here it is more clear. Patient is having the little stoop posture with narrow base, and stride length is mildly shorter than the usual.
Hmm.
The arm swings are bilaterally reduced, symmetrically reduced,
Hmm.
and he turns en bloc, meaning he takes around 5 to 6 steps while
No,
turning.
so I would differ on this. So, you can see, just go back again and just see how he's turning.
Ma'am, it will
He's
come on
holding. You
this.
can see that he is fixing the which leg is this left leg. Okay, he's
Yeah.
fixing the left leg and done turning. Just go back and see again.
So, ma'am, he is turning away.
See what is happening. One leg is fixed, right? The
Yes,
left
ma'am.
leg is always lagging behind, and he's using right leg more for turning.
Okay, ma'am.
Okay, so I'm not
Ah,
in favor of N block. Later on, I'll share a video of N block turning, which is very classical of entire body turns.
ah, yes,
Understand?
ma'am.
Not like one
Yes.
part remains behind and then the other part turns like that. In N block is
Okay,
N block, that is whole body turns. Okay.
okay, ma'am.
So I am not
So
in
this
favor of N block turning, but there is a little bit of pivoting and piecemeal also.
piecemeal, yeah, ma'am.
Yeah. There is one more phenomena in higher order gait disorder called as slipping clutch phenomena. What is that?
Yes. So, ma'am, there is shuffling of the body while
Not
initiating when
body, it is the feet. There's
feet.
it's
Okay,
like
yeah.
he's trying to, yeah, see now how it is turning.
Hmm.
The right leg is doing maximum work, the left leg is remaining behind.
Yes.
Okay, and there is a piecemeal. So short steps he's taking, multiple short. There's that also history you can tell. Many
Hmm.
times relatives will tell this history that when he's
Yes.
turning, he's taking multiple short steps while turning.
Hmm. Yes,
That even
ma'am.
further goes in the piecemeal turning pattern.
Ha. Yes.
Okay.
So this is more of piecemeal turning and
Yeah.
pivoting, slight pivoting.
Yeah.
Yeah.
But the
Okay.
base is narrow. That much I agree.
Yeah. Base is yes.
Yeah. But upper
And
body movement is not so prominent as compared to the low. I mean, upper body movement is also slow.
yes,
Associated arm movements are slow.
are slow. Yes.
Okay.
Yes.
Then,
Uh,
do we have full test on video?
ma'am, actually, pull test ka there is no video, but
Okay, fine. Just show
yeah.
this. Best is to show if there is any Archimedes spirals.
Ma'am, I just made him right. He didn't have any tremors. That's why I didn't ask for the spirals. But it's throughout. It remains.
Yeah, it is
The,
small, but do we have his older writing pictures?
sorry, ma'am.
Old writing for he must
No,
have
ma'am.
had some writing write up in the past, na?
Yeah,
On
ma'am.
his like we can compare that with the old one.
Yes, ma'am. But we
Okay.
don't have any. But they are
Okay.
saying the sun is also saying that it has become quite
Yeah, because
smaller.
the checks are bouncing, right? So
Yes,
probably
yes.
okay, but there is no dystonic posturing while writing.
No, no, ma'am.
Okay. I would consider the dystonia as a soft component to this as of now. Okay.
Yes, ma'am. Yes,
So somebody has asked you turn hesitancy and differential multiple. See, turn hesitancy. So that is what na. So slipping clutch is like when you're beginning the gait or when you're initiating the gait, you're taking multiple steps. That is slipping clutch like picture. Okay. And when you're walking, you're turning, you're stopping. That is turn hesitancy. Okay. And then you start turning, but you're taking multiple small steps. That is piecemeal turning. Understood?
yes, ma'am.
Okay. Okay. So now, any other video is there?
No, ma'am. Just these videos.
So, what possibility will you consider now? Summarize.
So this is 77-year-old male presenting with insidious onset progressive extrapyramidal syndrome, primarily with
Progressive symmetrical extrapyramidal syndrome.
progressive symmetrical extrapyramidal
Extrapyramidal
syndrome.
syndrome
Yes,
with,
primarily with gait
forget about
freezing.
primarily words and all that. No primarily slowing, nothing. with
Okay.
early
With
freezing of
early
gait.
gait freezing, with early freezing of gait and impairment of postural reflexes, hypophonia. Ma'am, should I take the pull test as significant and include the
Yes,
word
yes, yes.
impairment of
Yes,
postural
yes, yes,
reflexes?
yes, yes. With early
With
postural instability,
hmm, early postural instability, hypophonia, and micrographia without any higher mental function, sensory coordination, involvement or
no,
involuntary
without, see,
movement.
in here now, few words should come first. So, without any cognitive involvement, without any autonomic involvement, without any involuntary movements.
Yes,
Okay,
ma'am.
these
Autonomic.
things should come first rather than sensory and coordination and all that. Okay,
Yes,
keep it simple. So,
yes.
what will be the possibility first in this case? There's lot of there is lot of kinesia and rigidity rather than tremors or anything. Okay,
Hmm.
so I would consider PAGF variant first. Okay,
Okay,
you may
okay.
monitor the patient. Maybe he'll start falling within next 2 3 months, or the gaze may become slow.
Hmm.
Okay,
Hmm.
yeah. So what are the
Hello,
yeah PSP variants?
hello.
Hello,
Yeah, ma'am. Am I audible?
variants. Yeah, PSP variants. I'm asking.
Yeah, so PSP variants are PSP Richardson still, which is the classical variant. Then PSPP, which is PSP Parkinsonism.
Mm.
Then PSP PGF, which is progressive gait freezing. Then
Pure
PSP with
pure kinesia with gate freezing. That is PAGF variant.
PAGF, which is pure akinesia with gait
Gate
freezing.
freezing.
And then PSP SL, which is speech and language disturbance.
Mm.
PSP with FTD, PSPF, which is the behavioral FTD primarily
Mm.
associated with PSP. Then
Mm.
PSP PLS, which is primary lateral
Mm.
sclerosis.
Mm.
PSP OM, which is primarily with the oculomotor involvement.
Mm.
And um, yeah,
PSP ALS also was there, and
ALS,
cerebellum.
PLS.
Yeah,
Yeah,
and cerebellum also.
yes.
Okay.
And PSP CBD, which is
In
the
your examination, you have to add one more point that when you are checking his gait, you put
hmm,
the while turning, you put your foot in front of his feet
hmm,
and see if the visual cues help him improve the gait.
yes,
Okay, when you have
yes,
examined the patient, the space is quite open. So you
yes,
may
ma'am.
you can make it more prominent by putting certain chairs in between. Okay.
Yes, ma'am. And ma'am, should we do the dual task
Yeah, dual
routinely?
task also, yeah, it is very
Yeah.
important to do. But not everybody, I mean, gets, but especially those who have this kind of gait freezing, you should do definitely.
Okay, okay, ma'am. And ma'am,
Okay.
in the
Okay.
absence of
Yeah.
this non-motor symptoms that we had, like no constipation or anosmia, hyposmia or RBD, should we still keep
PD variant is less
PIGDS?
likely, but it is a different variant only, na? So you may
Yes,
not get the typical the symptoms of synucleopathy in this.
hmm,
Typical symptoms of synucleopathy because it's a kind
yes,
of freezing variant. And
yes, ma'am.
somebody asked, what is dual task? What is dual task?
So, ma'am, we asked the patient to do some arithmetic calculation or to
Yes.
hold something in
So
the
mental
hand while
arithmetic they
walking.
can do, or somebody can talk to the patient while walking, or they can
Walking,
hold the
yes.
book while walking. So
Hmm.
it is like asking him them to do certain more activity with walking. So
Hmm.
because of this dual tasking, the concentration of walking is gone. Okay, and then they tend to fall. The gait disturbances become more prominent. So you may see a lot of freezing with that. They may fall also with that. Okay, a lot
Hmm.
of gait initiation failure also may worsen because of this dual tasking. Okay, so gait disturbances more become more prominent those patients if you do the testing with dual task. Okay.
Yes.
Okay, fine. And then gate pathway and all you shouldn't remember.
Yes, ma'am.
Okay, fine. I think we can the session. So somebody has asked what is piecemeal turning. So basically, see, patient has just imagine a patient who has higher order gait disorder. So when he starts walking, there is difficulty in starting. So difficulty starting is gait initiation failure. Okay. So he's just stuck for some time to begin the gait. That is gait initiation. Okay, when he starts walking, you see that suddenly if somebody comes in between or some stool is there, some obstacle is there, he just stops. Or on its own also he may stop. So that is called as gait freezing. Okay.
Mm.
Then when he starts again, there might be multiple short steps he may take to start the gait. That is called as slipping clutch phenomena. Then he starts walking. Now he has to turn. Okay, so now when he's turning, suddenly he stops. There is a freezing there, and when he's starting to turn, there is a turning hesitancy. Okay, and when he's turning, he's again taking multiple steps while turning. That is called as piecemeal turning. Understood now?
Yes, ma'am.
Yeah. Oh,
Thank you so
okay,
much,
thank you.
ma'am.
I think good presentation. Okay.
Thank you.
Yeah.
Thank you, ma'am.
Anybody have any last questions? Okay.
Okay.
Then, madam, you can give final comment. Then we'll close the session.
Yeah. So when you're describing the extrapyramidal syndrome, so I told that in the beginning you mentioned gait, like how he's walking now, how he's lagging behind his peers while walking, the slow gait, the speed has slowed down. Those are the typical sentences that we use in a patient with Parkinson's. Okay, when they are walking slowly. So he's walking behind his peers. These sentences should come. And then when he starts walking, what are the difficulties? The freezing happens, the turning difficulty walking. Then you have to describe the falls. Then you can also describe the posture of the patient. You can describe the base of the walking. Okay, and then associated with that, you have to also mention the upper body bradykinesia symptoms. Okay, in which case you mention only writing, but there are other things which so you should have mentioned there. No difficulty in brushing and all those other. Okay, and once that happens, then you can go to the speech. And in speech also, when you mention no language disturbance, but it's just a speech, then there are many different types of dysarthria. So you try to rule that out. And if you say there is no swallowing difficulty or no nasal twang or no stridor, then we rule out those bulbar involvement at the same time. Okay. And once you finish, then you can definitely say that this is extrapyramidal syndrome. There is no other condition where you get the freezing of gait. Okay. I think that much is enough, sir.
Yeah. If
Yeah.
there are no further questions, we'll
Yeah.
close this session. Thank you, Swalia
Thank
madam, and
you. Okay.
thank you, Dr. Mauli, for nice discussion, and
Thank you,
thank
sir.
you everyone for attending this session.
Okay.
So we'll conclude. Thank you.